Hi, I'm back again with the wonderful Jane Hutchens. Jane, you were so kind and contributed 2 chapters, and the other chapter that you worked on was the pregnancy one. Thank you again for doing it. What a detailed chapter. I mean, just so incredibly detailed and specific, and such a strong foundational guide for clinicians. I mean, we heard before how you found women's health in your other interview, but how did you sort of get to work in such a specialised area as pregnancy?
So I guess it was evolution. So working in general women's health, and then when I did my Masters of Reproductive Science, obviously fertility and pregnancy was part of that, and it seemed just the next step to build on that, because you can only help so many women get pregnant and then just leave them. It was logical to be able to provide a continuity of care.
Yeah.
And, it's an amazing, amazing space to be in. It's a very privileged space to be in, and one that I think we really have to respect, because whilst it is that just almost incomprehensible magic, I don't quite know how it happens still.
Yeah.
And holding that natural, beautiful space and energy, but really knowing and needing to know some of the things that can go wrong. So in the text, I kept it based on normal, with some of the more common things that can happen, some concerns like hyperemesis or just nausea, and didn't really go into the higher acuity and higher pathology. But I think we do need to be respectful and mindful of that, because things can change very quickly, and can have really profound outcomes if we're not really aware of that. So holding that space and compassion, but having an eagle eye, and to be really aware of clinical science and acuity.
And what would you like to get across to clinicians or students when they look at this chapter? What do you think are some of the most key aspects?
Well, it's, for me, in my own work, it's this constant balance between normal and healthy to something that can become profoundly unwell and have terrible outcomes. In Australia, we have good results for maternal morbidity and mortality compared to America and developing nations. But to have hundreds of women every year die as well is clearly an unacceptable outcome. But it's also that notion of pregnancy, particularly the first pregnancy, is this liminal space. So you're a woman, not quite a mother with a baby in her arms, but when you do have that baby in your arms, you're not that woman you were before. So pregnancy is this fantastic mid-spot. And even if you're making a change, like, buying a house, change is intense and demanding. So holding that space for that woman can be really important. But it's also that thing around, in the book, I zoom down into the physiology, I should say, with a little pathophysiology, and try to get into that detail so we have that foundation. Then I really want people to zoom back out, because we can't reduce women to their biology. Patriarchy's been doing that for a long time. We can't do that as well. So we need to recognise that this is a woman, because she often gets missed in pregnancy and postpartum. So it's a woman who is pregnant. It's not a baby inside someone. Clearly the baby is important, but keep the woman foremost. And the woman is in a kind of an organic community. So there's her family, there's a partner, there's her work, there's the community she's in, and the society, and they all impact on how she manages pregnancy or experiences pregnancy, as well as motherhood and birth in the middle. So just trying to keep all of that in context and being respectful of that process, and intervening when and how we need to, but also knowing when we don't need to, and it's okay to just sit, and knowing absolutely when we need to refer, and being really clear about our scope of practice. I think that's really important. But just remember, she's a woman and a whole person, not just a baby carrier.
Absolutely. And I think, you also highlight on a really important point, which I know you and I have spoken about in the past at great length, but it's a very clear specialty of practice, and it's not one that whilst every woman can make a baby and can be pregnant, if you want to work in this area, you really need to know what you're doing, because you can do a lot of good and a lot of harm. And I think it's
Absolutely.
really important that people are conscious of it, and that's why your guidelines and recommendations are so important.
Yeah, thank you. Well, look, and I put off working in it as intensively as I do now for years, because I thought, no, I want to know more, and I want to be really sure that I'm ready and that I'll be safe. And I'm really safe. Like, that's just the way I work. That I wanted to be really, really safe because it is so critical. And the other thing is, we sometimes think of pregnancy as a moment or a period in a woman's life, as a kind of some independent event. But it's not. It's informed by everything that happened before and up to that point.
Yeah.
And of course that informs thereafter. But even for the whole of her world, but even physically and physiologically, how well she's in pregnancy will determine how young she is and how severe her experience of cardiovascular disease is.
Tell us a bit about that, because that's with your PhD research, isn't it?
For some of it, yeah. So we know just from women have hypertension in pregnancy, even if they don't get to preeclampsia, that predicts having cardiovascular disease to a more severe degree and at a younger age than if she didn't. So if you're working with someone who has heart disease, you need to ask her what her pregnancy was, even if she's 65. That will really inform it. But in my PhD, what we're looking at is trying to characterise cardiac disease or pregnancy-related heart disease, and pregnancy in the first year postpartum, because we don't know much, which is just this gaping gap in our knowledge, which is it still blows me away that we have no data on how many women in Australia have pregnancy-related heart disease. We know about preeclampsia, hypertension. We know about postpartum hemorrhage and gestational diabetes. We have no records about how many women have a heart attack in pregnancy or the first year postpartum. We have no data on how many women have peripartum cardiomyopathy. We have no data on how many women have pregnancy-associated spontaneous coronary artery dissection. And they're things that can kill you really, really quickly. We can kind of track backwards and look at women with congenital heart disease because they're already in the system and have been since birth, but we still don't have that data. So in my PhD, it's a mixed methods methodology. So there's a quantitative, we're doing a 12-month analysis of epidemiology of how many women have what sorts of disease and what are their outcomes and what are the outcomes for their baby. And we're doing that for New South Wales and ACT, tying into the Australian Maternal Outcomes Surveillance System, which is a specific organisation that looks at rare diseases in pregnancy. And even saying rare diseases in pregnancy, they're not, because the definition is one in 2,000 or fewer. But statistically, it's somewhere between 1 and 4%. That's the international estimate of conditions, and that's up to 12,000 women a year in Australia. So that's quite a lot. Go to the 4%, yeah. And the qualitative aspect of my research is probably where my heart is, but I like the numbers to inform what to do with my heart. And that's asking women. And my experience of some of those interviews has been quite profound. What has it been like? And that was my question. So what happened? What was it like? And it's changed me, to be honest. And we can't provide the care we need to if we don't know what we're dealing with. It's really basic. So, and we can't have woman-centred or mother-centred or person-centred care if we don't know what's happened to them, if we don't hear their experience of it.
Yeah.
So it's all very well saying, okay, we know this drug will do that, and that's fantastic, and that's going to save her life. But we also need to know, what was it like for you? What was the thing that you took away with that? How did it impact you 5 years later? So it's great. It's good.
Fascinating. I can't wait to hear about it more and read it.
Yeah. And it's an interesting space to be in because it is also cross-discipline.
Yeah.
It's cardiology and obstetrics or maternal care. So again, I'm in the middle of things.
But you've been so well at the balancing act.
Okay.
And it definitely comes across with everything that you've written. So thank you.
My pleasure. Thank you.
Good luck with the PhD. It sounds amazing and so vital, such important information to be able to research and to acquire. And second edition of the book. We look forward to an updating clinic site.
I'll do a whole chapter on cardiac disease in pregnancy.
Yeah, no, amazing work you're doing. So thank you. And thank you for everything that you did with the team.
Thank you very much for letting me contribute, Leah. It's been wonderful.
Thank you. We'll see you soon.
Bye-bye.